marriage, oh, we need you elders to help us step in. There are some things that we've done well. There are some things that we are doing well. There are some things that, we need to look into. And that's basically why we are here today. We started that yesterday, and we had presentations on the different programmed areas. But one thing that we needed to conclude on that particular what happened yesterday is the fact that we need to consolidate. What are those shifts, the programmatic shifts from G66 that we took into G67? What are those things that happened? Right? What are those things that happened? So I want Dr. Moni, it would help us. I'm consulting with one of the elders. Okay. A round of applause for me, please. Thank you. So Dr. Money would be running through those sheets from GC6 to GC7. But that's not the first. So please, can we have the new agenda for the wedding or the events? Please, can we have the agenda? Okay.
All right, great. Thank you very much for that. So just like I said, the agenda has been updated and reviewed and tweaked and designed so that it really flows with the conversation of today. So Ngozi, if you can just kindly put up the agenda, that'd be great. Fantastic. Blow it up a little bit and we should be good to go. All right. So you noticed there were some topics yesterday that we've moved in today. And is there any way you can make it a little bit bigger so we can see? Can you see this at the back? It's a bit difficult. So if there's a way how you can blow it up, that'd be great. Yeah, amazing. Okay, so this is the grand finale, day 2, and we're going to be looking at integration, innovation, scale best practices, and ownership. So if you scroll down a little. Okay. All right, I think if we can expand it a bit, just because this hall is so much bigger than yesterday's hall. So it means that I am sure some people at the back are screening. People at the back, can you see it? Exactly, they can't see it. So help me out here. Right. And while we're doing that, if anyone can just push it to Tire Team by email, so everyone has it in their devices, everyone has it in their emails, that would be excellent. Let me just read it out, just so that you can see what we're doing. So today, it's going to be all about the program being led and driven by all of the actors in this room. So that's the program managers, as well as WHO that kindly started warming up the conversation. And we're really going to be looking at a one-page summary of our programmatic gaps and challenges in HIV and TB, right? And the objective behind that is so that we can get a perspective of the improvements needed from the state representatives. And then finally, because I know there was some chatter yesterday that a lot of the things we're doing, are they actionable? Are we going to have changes in terms of our service delivery? Yes, we are. Because right this morning, we're going to be having recommendations for improvements from the states. So we've listened to you loud and clear from day one, and we're pulling all of this into the conversation of today. So we're going to get your recommendations. Recommendations, please, for results. Not recommendations that we need to change the objective of NASCAP or change the objective of NACA, or we need to change the Ministry of Health and make it the Ministry of Integration. Ladies and gentlemen, that's not going to fly, right? We're looking for things that are actionable at our level, at the community level, at the state level, and also for decision makers. All right, we're still going to continue the conversation using Mentimeter. So if there's, particularly for those on the online community, we really want to see how we can reflect their voices here. So we're going to use a Mentimeter to also see how we can generate and co-synthesize a little bit more recommendations. And for this morning session, we're going to conclude with a spotlight on the cycle 6 into cycle 7. What, ladies and gentlemen, were the key shifts? What were the approaches? What worked? What is working well? What needs to be refined? What needs to be scaled up? What needs to be replicated? What needs to be adapted? What needs to be contextualized? And we're going to do that so that all the review areas requiring our strategic assessments are used in such a way that we can re-engineer cycle 8. And cycle 8 will build on the gains, build on the lessons learned, build on some of the challenges that we feel may still exist, or even vulnerabilities. And we're going to roll all of them in so that we have a playbook for cycle 8. A playbook that from the word go, we know that day by day we're going to have success and we're easier able to navigate our challenges. Thank you very much for that. And then we're going to have the big elephants in the room. Can everybody say the big elephants in the room? Say the big elephants in the, that's not me. Oh. All right, so we're going to tackle integration head on. And that's why you can see that building on the conversation, the rich conversations of yesterday, immediately after you've energized yourself during break, there we're going to step into the conversation, step into the room when it comes to integration. And we're really going to be talking about what has been accomplished. Notice, we're not asking what is integration. We're asking what has been accomplished. Ladies and gentlemen, what are you doing out there? A few states reached out to me, nudged me, and said, "You know what, Chris, we're doing some incredible things. I'm happy about you was able to vocalize that." A few other states said, "You know what, there's some incredible things we're doing in terms of integration." Oh, you have been accomplished on that. Based on that, what is next, right? And then we'll have a really great lunch and prayers, and we will be concluding this grand finale with session 4. And session 4 is really going to be celebrating ourselves. Can everybody say ourselves? And give ourselves a round of applause, please. And this time, I mean round. Give me a round. Yeah. Some people, that's a square, guys. Round, man. Give me a round of applause. Sir, I love this one. He's giving me some fire. Bauchi's giving me some fire here. So we are going to be celebrating ourselves, guys. So this is going to be celebrating ourselves, state recognition, and closings. So we're going to look at the key action points that we've been able to take forward from day one. We've been able to build in the morning conversation and the conversation just after tea break. And we're going to have what are the key actions and the next steps. And then we're going to go into the states. We're going to recognize states. We're going to recognize the hard work that you've been doing out there. You're not unseen. We hear you, we see you, we feel you. We are going to appreciate you, and we are going to recognize you. And that's what we're going to have here with the methodology used to determine the best performing states in HIV and the best performing states in TB. And really come out like, okay, in the state award ceremony, we're really going to talk about those states, celebrate those states, but also be mindful and reflectful that there are other states that are in a rebuild right now, such that a lot of those lessons learned from these states that are going to be celebrated, we're really looking forward to a wider celebration as we enter into the next cycle. And then, ladies and gentlemen, it's going to be Friday. Thank God it's Friday. Closing ceremony and photo sessions. So I can see a lot of people are looking very beautiful. I'm seeing a lot of Friday beautiful. Ma'am, you're looking great. Is there anyone wearing red hair? I can see it's the men that are wearing red. We have a man wearing red in the house. Can we celebrate the man wearing red in the house? All right, I made sure I didn't wear red. You're most welcome, sir. Ladies and gentlemen, we had a most distinguished dignitary that just joined us right now. Recognizing you, sir. The special advisor, your senior special advisor, you're most respected and welcomed. All right, can we give him a round of applause, please? We can do much better than that, please. All right, thank you very much. So, ladies and gentlemen, that's a wrap in terms of what we expect for today. Are you excited? Is that how you show excitement? Ladies and gentlemen, I think maybe you didn't hear what I said. Are you excited about this? Yeah, I'm so excited by it right now. So with that, I'd like to kindly continue the conversation as we transition with WHO, the program managers, roaders, and the entire team. Thank you.
Thank you so much, Dr. Chris. Let's give him a round of applause. So let's continue our story. Can we have the bride and the groom? The bride, you know yourself. The groom, you know yourself. Hallelujah. Please.
Hello. Hello. Good morning, everybody. Now, the way you answer is by there is a problem in this. Did you sleep well at all? In that kind of room they gave you, I can understand the other people who didn't sleep here, but the people those who sleep here should. All right. Good morning. So we are going to, yesterday we had a series of presentation, and as we go through those presentations, there are key points that we have identified that needs to be discussed further. And like Chris said, please do not come and tell us that you need to change the inadequate funding. Because if I tell any of you here to bring 1 million naira, you will run away from this hall. So just tell us what within the available resources you have that you can structure to get a result. So if we do it that way, we can have an actionable point that as we're living here, we'll be able to deliberate on it and provide the necessary support that you need to get it done. So we will present those points as based on disease, but it's going to be on a one flip sheet, and then we now go through it one after the other. And in this discussion, please, we want mainly the people from the state to respond to them, because you are the implementer, you're the person doing the job. Community people, these are the people we want mainly to respond, because we want us to know, because most of the times when we say these things, we think it's as easy as ABCD. When we go, I can say, go and do case finding. Then you enter there and be doing case finding. I don't know what it takes to do case finding until you go to that point. You say you are doing supervision. You now see that this person you're saying to do case finding is crossing river, and you gave him money for by road, but he needs to cross river to get to where he needs to do the job. So some of these things, so we want to feel it from the state. We will not allow most of the people at the center to talk much. We want the state people to respond efficiently and effectively to that. So please, state people, if you are back, we want to be seeing your hand when some of these discussions are going on. And then the community, because you are the community, you are the people working at the back end of the whole thing. You need to get back to us and say, okay, even though we said the community is working, these are the challenges that we face, and this is how we have been able to surmount it so that other people can actually learn from it. Is that okay? And please, we have to be snappy. We have to work with time. When our time is up, there's some people who has more. You don't know how muscular Chris is. He can lift me and put me on the table and change media. So let's work with time, and let's not exceed our time. But please avoid, this kind of thing. Based on what Dr. Obioma and Dr. Moni have said, I just want to reiterate. Don't reiterate. Immediately they say we have had it. Don't help us to hear more. Give us, if you have another thing to say that is different from what they say, please respond. But if you don't have anything different and you have raised your hand and somebody before you have said it, just bring down your hand, say, don't worry. Is that okay? So that I don't find a situation where I say, Dr. Quinn said this, and then I repeat what Dr. Quinn said.
Thank you so much, the groom. Please, you have a seat in front. And the bride, please, we need you to sit there. You have all your people, all your family members from the States. So please, we need you in front, please. HIV, yes. HIV and TB. Please, can we have the presentation? Of course. So before the slide comes up, probably from the people in the room, if you are from the States, if you are with the groom, please, can you raise up your hands? You are with the groom. You are with the groom. Please, can you raise up your hands? With all the announcements we've been making, the groom is TB. HIV is the bride. If we are with the bride, please, can you raise up your hands? Okay. So, you are with the groom now. Yes. Please, can you tell us, based on what your brother said, can you tell us one or two things that you think will come up in that?
Thank you very much for giving the opportunity. I'm one of the grooms from Ondo State. I'm the state program manager for Ondo TB, leprosy, and Borrelia ulcer control program. I'm Dr. Aino. And once again, Global Fund, thank you for the privilege to be here. One of the things I expect to see in that presentation, which is what you've asked me, is that I expect that this marriage that you have asked to work by all means, I expect to see how the marriage is expected to progress. Of course, from my state, we've done a bit of marriage, and the next phase is how to solidify the marriage. So I expect, yes, I paid. I've paid the bride price. Luckily, I have a very fantastic SAPC, yes, the SASCAP program manager, and of course, my big brother, the SACA DG from my state, is also here. I'm surrounded by immense facility, so you can be sure about that. So I expect to see how this marriage will progress in a stepwise fashion. All right, thank you. One of my family members from Kogi State.
Thank you very much. One thing I'm seriously expecting to see is the children, or let me say the main child they are going to give birth to, which is the integration, and probably working together with one budget, with one planning, and moving together, doing our supervision together. Those are part of the kids that I'm expecting to see in the presentation and how that will be successfully done. Thank you very much.
Have it. Can you project it? Are we ready? Not yet. So the family of the bride, let me start with the Olori Ebi. What are those things you're expecting?
All right. I'm from Aziz Eric M. Akoji, formerly of Kogi State SAPC. And right now, my presence here is more or less like what I've done so far with my people, as I'm going to be a little bit out of the space because of God's honor. I've been promoted and appointed as a permanent secretary in my state. So, what I'm going to see there is just like my groom have said from Kogi State. The journey was not easy. The marriage of integration coming together was not easy. I think even when half, who is the sub-recipient for IHVN came, it played out. But at the end of the day, they can see that that rough beginning has brought us to where we are right now. I want to see some of the gaps in the presentation in terms of commodities that are driving this marriage, because we have not been able to test all our TB clients who have been screened for TB for HIV because of test kits. It has not really made us to get to where we are going. Secondly, we have been forced by the marriage to work together by having what we call composite work plan. We are seeing this person from having visibility of the two programs' activities, and then our involvement to work together and achieve result. So I believe that in the course of this meeting, more avenues for this collaboration, especially at the hinterland. What Emperor was saying, we need to be more granular in our programming in terms of resource allocation. Thank you very much.
Thank you so much. So the groom, you've heard from your family members. Over to you. In the next 10 minutes, can you do that? Yourself and the wife, in the next 10 minutes, can you give us what it's about?
Yes. Okay, good morning. Please.
I think we want to start with quarrel. I am the neck and he's the head. And now he wants to push me to the back. Okay, move, go on. Good morning, our families. I'm a very submissive wife, oh. But if you look for my trouble, and when we were putting this together, he said we should start with the HIV indicators. And we looked at it and said, we have been married for long. This man started investing before me.
God bless you.
As a good husband. Are you not supposed to rub off on my indicators? But we're not doing well. I hand over to you.
All right. People should not get worried. These days, this is the kind of marriage that lasts long. You know why? Because I don't know whether what my father told me is true. He said those days when the wife is forced to, you have been given wife to, you are not the person selecting. And then all of them grew up old. But now we are saying that it's love that is managing the thing, whether it's true or not, and then the divorce rate is very high. So this one that is we are doing like this, this is a forced marriage, so don't worry, it's going to last for a long time. So we're going to start with HIV. Please, we also want to be very snappy, and we can look at, if you look at the listing, for instance, you say these are the programmatic gaps that are identified. The first programmatic gap identified on this was coverage of viral load suppression is still suboptimal. Okay, we are talking about 70% and 81%. Okay, for viral load. Yes, ART coverage and viral load gap. Don't worry. You are seeing that. You know why? Because we have not been talking together.
Speaking together. So we're going to solve it now. The root cause.
Yes.
Too many wives, concubines. But today we're going to prioritize my problem. So husband, it is pediatrics ART coverage.
You see, so pediatric ART what? Coverage. You see, the most important thing we need to do is that we understand that most of the times the major problem within TB and HIV is that we are not speaking to each other at the state level. And I give you an example. We have community HIV, community TB, community wife, community husband. Everybody is doing on his own. So TB should start reporting even some of the HIV indicators as part of their role and vice versa in the system. But let's also hear from you, and we don't want it to be that it's only HIV group that will talk. We want also the TB people to say, if you are having, because pediatric issue is not only a problem for HIV, it's also a problem for what? TB. So now, from what the HIV people will say, how will we come in as TB to support this process? Please, we want 3 hands, 2 HIV, 1 TB. States. 1, 2. Why are these big people only raising their hand? That's what I'm saying. I'm coming to my okay, Gele too. So let's start from His Excellency.
All right, thank you very much. I think we are with the recent programming, especially the Child TB week. If you notice, before now, it was TB that was driving the process. But this year, there was an improvement. Why do I call it improvement? Right from the national, all the engagement for planning, the states were involved. Even the SASCA people were called upon in the Zoom meeting for us to offer 1 or 2 things in terms of how it can be done perfectly. And during the week itself, there were deployments of both SASCA, TB, and other stakeholders to participate in the screening of the children in the zones where we think that there is under screening of our children. Like in Kogi State, we have it in about 5 local governments. So, morning, sir. And like I said earlier, some of the children that were screened, we could not get HIV test kits to what? To screen, to know their HIV status, but they were screened for TB. So those are some of the things that I know that the coverage for ART among pediatrics can be increased if we double our effort in addition to what we have done this year as we go back home. Thank you.
All right, Your Excellency, sir.
Thank you very much. Just in addition to what I just said, I feel that the issue of stigma and discrimination is still a challenge, and we need to work with structures that can actually remove all the barriers that we're looking at pediatric pediatric coverage. And yesterday, when the TB focal officer was making a presentation, I actually mentioned they have some gene experts that we can also leverage on to do viral load testing. It will actually help the turnaround time for us to get results and to actually move forward. So it's important for all the structures on ground at the state levels to work together. This marriage that you're talking about, I hope it will last, and we pray that it will last. Having said that, I feel that there are some strengths that the state agency control of AIDS actually have concerning the ART coverage at the state level, because we actually need to move out to the field. Yes, we are not implementers, but we have the capacity, yeah. We have the budget, we have the resources to actually strengthen also SASCAP to do the needful. Thank you.
Thank you very much for your contribution. So yesterday we had observed that out of the, I think, almost 5,000 cases of new cases of HIV in children in 2024, about 80% of them came from the family index testing. I think 3,950 thereabouts, which is very significant. And we observed that sometimes, I think with the stop work order, that activity was affected. So as state program managers, how do we intensify and pick this up? It's something that we really need to drive. What are the actions? What are we going to do? And if you look at our projections, we don't have states listed there, but we know that in some states, this is more, it varies across different states. But we're not specifying the states here. What we expect that we go down to the state level, look at our data, right? Sit with our implementing partners, pick up our data. Could it be data quality issue? Could it be incomplete reporting? We really need to start addressing this, and we need to sit at the state level. The stop work order, the fund, it's real, and that's the reality. And so how do we sustain the gains that we have had and address the gaps? If you remember, we had said that is one of the objectives of from last year continuing to this year. So we really want response from you. How do we address this? And this is going to cut across almost all the indicators, because we know that at the national, we keep sitting down, discussing here, but what happens when we get to the state level? How do we take it on from there? So anyone to, please. Sorry, sir. You're my husband's brother. And as a good in-law, I need to know you. So when you're introducing yourself, please, I would like to know your state so that when I come to your state, you can treat me well as the in-law.
Thank you.
Thank you.
From Kebbi State. I'm the program manager for TB and leprosy control in Kebbi State.
Thank you, my brother-in-law.
Yeah, thank you. I'm just looking at it as service delivery points. Can we get a comprehensive facility setting where both TB, HIV in the same room, and also we have a gene expert where people screen for HIV, can access TB services, people screen for TB can access HIV services. And if all this comprehensive care is together, ARVs are there, TB treatment is there, we have gene expert in the same facility, I think we can close the gap. Thank you.
Thank you very much.
Thank you very much. One other thing that I think is like a gap is, okay.
State.
My name is Dr. Komalafe Rotimi from Kogi State, TB, leprosy, and borreliosa program manager. Thank you very much. Like he rightly said, service delivery points, primary health care centers, where it's the closest to the people. How many in the country are actually carrying out HIV testing? And sometimes you find out that they are doing TB activities, but HIV testing is not there. And we have tried in some places to probably do hub and spoke. These PHCs, when you need HIV testing, go to this particular place, but how much of it has worked? I know if you can strengthen that, it will also go a long way to make sure that the children will be able to access all these facilities. Thank you.
Thank you very much for that question. I'm Mrs. Ilesomitayo from Ekiti State Ministry of Health, Saska. I want to talk about the family index testing that you mentioned. You know, sometimes ago, I think about 2 weeks or 3 weeks ago, we had a meeting with our implementing partner. We discovered that we have disparities in our data, in the aspect of the one coming from our side and the one coming from the partner. So we now start together, we're now thinking, we are now doing a deep dive into what actually caused the issue. We now discover that there are some testing points that IT is capturing that we, SASCA, we are not privy to the information. So we now just start, we now divide a means of how we can get the data, the partner and the one coming from us. Like we now agree that second week of every month, we will be coming together, sitting together, harmonize our data before reporting. Then secondly, I want to talk about the issue of test kits. During the childhood TB week, the TB program people, they called us, informing us that they are having a week, childhood TB week. But unfortunately, we don't have testing kits at the time. The only testing kit we have in the state is combo, which we cannot use for pediatrics. So these are some of the challenges that we're having at the state level. If we have means, although we've reported to the authority, the stakeholders, they are aware. So they are making sure that we get test kits apart from the combo kit that comes from the national. At the state level, the marriage is working already with TB and HIV. It's just that the means of making it even work better is like a challenge to us. Thank you.
All right, thank you so much. Please, a round of applause for all of us. We are getting somewhere. What's good thing that we're having is that nobody is telling us that we need to build a new primary health care center. You know, for us to get this problem resolved, we are looking at what we can do with the resources that is actually what available. And I assure you we can really, really do that. So let's proceed to the next session. We'll still, if we have time, we'll still come back to ask for more discussion. So I will leave Dr. Moju to go to the second one, then I'll now take the third one. So let's go ahead.
Thank you very much, Dr. Emperor. For the second gap, we identified that we begin to notice increase in the yield. And this is a very, very important indicator that we need to focus on. When we went deeper to look down to the states, I think we've listed some states. Edo, FCT, Oyo, Kwara, Nasarawa, Kebbi, Taraba, Zamfara, Enugu, Delta, Kaduna, Abia, Adamawa, and Ondo. And these states have above 2%. Some a little bit below 2%, but the difference between the previous years, looking at the trend, is quite significant. And I think it's something we need to keep an eye on. At the national, we've also gone further beyond the states to look at the genders and within the different groups. But we really need that to happen at the state level, to begin to look at where is this coming from? Is it a particular area? Is it a particular local government? Is there a hospital that we need to identify and find out what is happening there? And so those are just our thoughts as laymen. But we need our experts at the state level to tell us what are we going to do, how are we going to address this, not to lose the gains that we have made over time. The gains that we have made over time, right? So I just took our time to explain these indicators to us. What are we going to do? The previous speaker has spoken about test kits. These are realities. We're also aware that now we do targeted testing, from the family index testing, social network testing, they're all targeted. So what is the root cause of this increased yield positivity that we're recording? We need to, yes, please. Dr. Emperor.
I'm here. You can ask the first question.
Thank you very much for giving me this opportunity. My name is Lehman Daladi, the TB Program Manager, Bauchi State. We expected an increase in more especially pediatric cases when we improved the case finding. Like in my state, when I understand that the childhood TB cases was very low, then I directed all the TBLS to earmark the indexes, the TB positive patient that are having children. Do you understand?
TB or HIV?
For TB and HIV, because we have an agency.
Okay.
And maybe if I make my presentation, you will see we don't have gap in that TB HIV testing and notification. Okay. Because just of recent, after this Trump declaration, we intimated His Excellency the Executive Governor, and he approved some money for the procurement of test kits in the state, in Bauchi State. Yes, and that goes a long way in covering the gap of unavailability of HIV test kit in the state. So what I did is I asked my TBLS to identify indexes that bear children, TB positive patients that have children. So I asked them to go for contact tracing of those positive TB cases that have children. That goes a long way in improving our TB cases. And as well, the integration of TB and HIV. I think we were able to detect two children that were co-infected. So when you increase your case finding, it increases the total number of the cases, and it must indicate, you must see them clearly. Thank you very much.
Thank you very much. We hear you that the strategy for TB HIV case finding, right, is what you think is going to contribute to the yield in HIV cases in pediatrics. But is that what is happening across all the states? Now we're asking our state colleagues. He has spoken about his state, and that is what they expect to see. But the point is that what is happening across all the states? How do we know what is really contributing to this increase that we're seeing? We need to actually be proactive. We need to go down to the states, look to our data, find out what is happening.
Is there anybody within the state that has an increased testing result that's among those people that have gained this 2%? Can you tell us what you did? You understand what I'm saying? Because we have low and poor. Okay.
Good morning, everyone. I'm Adeleke Fidel from SASCAP's office, Osun State. Yes, at the time we have this, when we noticed of this low pediatric outcome, so what we did is, first of all, introduction of the alternative point of entry. And it really does wonder because many people that were missed earlier were captured. So we have some few children that were captured during that period. And also, we also have to call the two main IPs in the state handling the HIV, and we call the EQUIS and the Damien Foundation, how they can help us to be moving samples from any part of the state. Once there is any suspected case or a child from a high suspected this that we need to capture, so immediately the sample will be picked and they provide riders. So we have riders now that financed by Damien and IPs. So they always pick movement of sample across from one point to another is now very effective. So all they need to do, we have a group, we have formed a group that they will just put, I have a sample. And immediately they say, I have a sample, immediately the writer go there, pick it, and take it to the APMA site. And the APMA release the result the same day. In fact, within hours, the result is out. So it has actually helped. And many parents are now more confident before they feel, if I do this test, when do I get results? But now we just tell them, your results, you are receiving it the same day. And it has really helped in our state, Osun State. Thank you.
Sorry, can you give us an example of what you mean by alternate?
Yes, now, before, it's not, we have the family planning, when they go for family planning, when they take the child for immunization. So all the points now in the hospital are giving they have to do the assessments, giving them the screening assessment. So any child of high this will immediately referred for testing. So it's not only just waiting for the delivery points or every point that the child attends in the hospital. Any child, the parents brings any child in the hospital is being screened. So all the points, we have a meeting with all the points. We have a meeting with them and they give tools, advice, train on how to do this screening. So any parents, any of the point, they have their screening facility, items with them there.
Thank you so much. Please, a round of applause because that's the meat of the thing, because we need to know how it is done. And this example she has given is not only for HIV testing. I think TB also should also borrow a leaf to that multi-sectoral this is. So when you are having that discussion with your SAPC and your SACAs, please make sure that that discussion about going as a unity, as a unified entity to address those points are very essential. Please, another round of applause.
I think one more point to just add. I think out of the last 4 speakers, 3 of them had mentioned looking at their data, sitting with their implementing partner. I think we should actually add it to one of our action points. We really need to pick all these indicators at the state level, sit down with our partners and look into the indicators. The pictures are going to be different across the states. And without going to your state to look at it and say, okay, what is different? What is contributing to this? And that is how we can have the root cause and what is contributing to the performance that we have recorded. And just to buttress her point, a slide was presented yesterday. And out of all the facilities that actually implement alternate entry points, 38% of the positives identified were from other points from PMTCT. So, and that's quite significant, where 33 out of the 88. That is what we're trying to. No, sir, you're not.
Okay. I just want to be sure that states are actually sitting down with their partners and looking at data. Because I remember just last week, we had a zonal review meeting, especially TB and HIV data. You know, HIV data comes every month, while that of TB comes every quarter. So that time difference, does it affect in any way? And how can we solve that?
Thank you, sir. I think that's the big question. Do we really sit down together to look at our data in our offices? Do we have a schedule for that? That maybe once everyone, maybe the last Wednesday or last Thursday of every month, we sit down to look at our data. Or maybe, as Dr. Clement had mentioned, maybe the last week of the quarter, considering the reporting rate of the reporting timeline for TB program. Is this something we do? Any states that wants to share their experience? What do you do so that we can all learn and agree on what to take forward? And I think that's how we're going to end this session.
We don't share data, TB, HIV data, but we do with our implementing partner. HIV data is not TB. Yes, we sit together.
Okay, so out of our state colleagues here, how many states actually have this scheduled periodic review of their data? We're not talking about when we have big meetings and we call and sit down. No, deliberately sitting down with 4, 5, 6 persons and really looking into your data. Can we, with show of hands, please? Frequently? How frequently, please? Monthly. Okay, if it's monthly, can you please? Monthly? Okay, so we do that. Weekly, monthly. Okay, so we've heard of weekly, monthly, but now that we do it, I hope we really go and identify these challenges. So beyond sitting and looking at the data, do we really bring out these challenges and deliberately put out action points on how to follow through with what has been identified? So if we do that, then we expect you to be telling us why we are having this gap that we're seeing at the national. You know, one of our colleagues, my sister, has mentioned something, that when they looked at the data they have at the state is different from partners. Could that be contributing to this? And these are real issues that if we do not address and have systems to address, we will continually come here, see gaps, talk about it, go home, and nothing really happens. And time is ticking. Money is reducing, right? And we need to be more proactive, deliberate, and identify effective action points that we're going to use in addressing these challenges. And I can tell you, if we decide on just this one point, it's going to address almost everything on the table. State colleagues, you are not helping us, so our marriage. Very soon, and you soon hear about the divorce. Yes.
Yeah.
I'm Shehu from Kebbi State.
Thank you.
From TB angle, we are doing what we call data harmonization at the local government level, where LACA is there, TBLS is there, general healthcare workers there. We do monthly data harmonization at the local government level.
So I have one question. Why can't we do monthly data harmonization for TB and HIV at the local government level?
That's what I'm saying. That's what we do.
So we do it.
Presently, that's what we do. Yeah.
What state?
Kebbi.
So
In all the states. In all the states.
All the states.
Yes.
We look at our data at the LGA level.
Yes.
Yes.
TB will face their own data. Even LMCU, they come to that meeting. It's not that we harmonize our data together. But what we do, for Ekiti now, what we do is that during the harmonization, we invite the LACAs, we invite the TB, we invite the LMCU, even nutrition at times. So what we do is that we harmonize the data that comes from every SDP. Then we do, like HIV will face their own, TB will face their own. Then the logistic data too, we harmonize. That's what we do. It's not that we now identify. What we now do is that we identify gas that come from HIV. We identify the one that comes from TB. Then we'll now see where the disparity is coming from. That's what we do.
So they said this is what she does in her state. But can we just give one program manager from TB to say what they do so that we can?
Thank you very much. Once again, Dr. Aino, Ondo Program Manager. Okay, so that is a picture, of course, that we have in the harmonization activity every month in our local government level. Now, from what you have discussed, one of the things we don't do, which of course we will do going forward, is there's a difference between harmonizing and reviewing. So all we do is to harmonize so that we don't have a gamut of data just there. Going forward, you're asking for a review. Sit down and look at the data, speak to the data. Data speaks to us. Thank you very much.
We clap for him because we've solved. I see your hand, but I'm coming. Review, because we harmonize. And what do we call garbage in? And so we come to the national and see the garbage, right? Please, can we start reviewing at the LGA level? I think it's important that we do that. And I can say that if we do that, it's going to affect almost all the indicators that we have on the table. So I think that's one very key action point that we're all taking away. And if you're with us, can we say hi? Hi, I didn't say hi. Hi. Thank you very much.
Thank you so much. Please, a round of applause. Big round of applause. I think we have done justice to this. So, but they said now that men have been functioning well, but the boss of the bosses.
You need to complete that statement, husband. You can't function without me.
I'm sorry, I need to make this comment. For me, I'm worried. You talk about TB/HIV integration. I don't know how many years we've been talking about integration. And if we are still faced with basic problem like this, do we also need to know why are we still looking at basic problems? Because for me, we should have passed this stage. We shouldn't be talking about we don't even know, we need to review data and all of that. Are there basic problems? Are there issues? Are there root causes? What are the problems? Why have we not moved forward by now? What are the issues? I don't know. Or am I not making any sense?
You are making very big sense. And that is what we have been telling you to give us the feedback. So please, this accent, what is the main reason that we are not doing data analysis at the LGA level? That's it. At the AGA level. Because we do copy the data, but do we really analyze or review the data? Data harmonization is A and B. You say I have A, you say I have A. But what is the reason for review? Your Excellency there. As I see your local cap.
All right, thank you so much, Dr. Charles Odimaf. I work with Society for Family Health and the project director for Global Fund and Trade. So I think the question that our boss of the bosses just asked now was in line with my thoughts as we were going through the exercise, in the sense that if you look at the framework we have there, we are skipping the root cause. In some contexts, like you look at that framework and we are preferring the solutions. Sometimes when we do this, as we've seen in programming, whether it's systemic review or performance-based review for improvements, we will discuss it, but at the grassroots, when this is to be implemented, it would not carry that flow to giving us the results that is expected. So the root cause is very important because I was just putting down like some steps, and if I'm permitted to just run through a few so that some of the teams here can also take them. So if you look at the gaps, we go to either using the root cause analysis or the fishbone to identifying the issues. Now, in identifying these issues, the issues can be like a mental dump box where you have all issues. But if we go to that granular level, those issues, we need to do two things. First is classify the issues and rank them. In classifying issues, at this point, we should look at what issues are national issues, what issues are subnational issues, what issues are bilateral. At the facility level, they will look at what issues are internal, what issues are external. A facility staff should not be saddled with trying to solve the external issues. They should narrow down to the ones that they can solve, that can close that particular gap. And like he said, if we start doing some of these things at those granular level, it will go a long way to helping us. In ranking, you might have a mental dome of 100 issues, but how do you know which issue is very important, very essential, which issue is just essential, which issue is not even essential? Because if we don't do this ranking, looking at either the likelihood of occurrence or the level of impact on our program, we will not know how to rank. And you can see us majoring in the minor. You can see a lot of effort, maybe trying to do coordination review meetings, whereas maybe the issue is that the data that is even coming, the root cause is that the data that is even coming is the problem, or the data entry clerk that is entering the data or the service provider does not even understand the indicators that we are reviewing in. So I think that we should take this and try to, as we go back, because it's in doing this, we can properly state what the problem is. It's when you state the right problem or you define the right problem statement that the solution would give us the right results that we expect. So let's try to break these issues down, look at the issues and cascade them. And then if we do some of this analysis, it will help us to drive into us what indicators do we need to track to close for these issues as we are resolving them, and how improvement can be measured over time.
Please, a round of applause. Thank you so much.
All right, so thank you very much for that question. The question is, to me, it's not a question like it's not a problem, like I've all said. It's just our selfish interest. What am I saying? If we, and we're already on course, plan before now about data harmonization at the local government for TB and HIV, which we have started. So the next thing now is to move it to where? To states, which is by the way of program data review. So there shouldn't be anything called HIV program data review or validation at the state, or TB program data review. Let us bring that we are now doing HIV TB program data review. Most time, if TB is holding their data review meeting, my colleague is here. I'll say, why am I not there? He said the budget does not accommodate me. Yes or no? The budget did not accommodate me. So what am I going to be there to talk about HIV? So now we are saying the marriage, collapse everything. It will become one review meeting for HIV and TB. And then when we come there, everybody owns the program and we can now speak. Why will you test so number of people for HIV and they are not tested for TB? Then we begin to sort those things out. That's all. So let's break the barrier and bring the integration to be one. Okay, that solves the problem.
Okay. Another action point.
Thank you very much. Actually, there's a weak data culture, data use culture at the SDP. The focus is on submission. Let's just submit it and it gets to the states. They don't bother to do any form of analysis or decision making. So now that we're now going towards that marriage that you're saying is something that we have seen at the state level. It just didn't mention it from those states. We have, I think, is it quarterly now that we do a data review? But the truth is, if you don't get it at the SDP, whatever you are doing at state level. So now we're saying that for HIV and some other, that the head of a facility should sign off on each of the data coming from the facility. That means after they must have done data cleaning, yeah, and review at that point, and let them analyze it at that level. Thank you. Yeah.
That question is there a capacity issue? Is there a capacity issue and a human resource issue at that level? Because we need to be very clear, is it not? We need to be very, very clear. Because sometimes you may be telling somebody to do something, but that person do not possess the capacity to do it. You understand what I'm saying? We can actually use this integrated program review at the state level to also build that capacity. Because for us as TB, it's a very big opportunity for us. Especially as it deals with human resource issue. So I think critically three key things that have come out is, one, do we have our attitude to data? Do we usually like speaking to the data? That's one. Two, capacity of the persons. Three, integrated program review. These are three key issues that there have been a separate program reviews. And when they say yes, when people say yes, we can do it, then they cannot talk about fund because they can't say we can't say yes without the fund. No problem. So please, a round of applause for everybody. Please, because of time, we're still going, we still have few things to cover, and then we have to be very snappy now. So Paul, what I was saying is that they say we are doing well, but our wives are not carrying the thing to the ANC unit. Hello? They say we are doing well in the house, but now the product of that is not being carried to the ANC. So who can tell us the two reasons or three reasons why community people, now you have to come out, why those people you are pursuing in their houses are not coming to the health facility? I'll start with you, with the boss here.
Okay.
Okay.
Good morning, everyone. I'm Dr. Chukwulo Ogochukwu, the state TB program manager for Anambra State. I will talk about my state because since 2023, the governor of my state launched a free ANC, free deliveries and free cesarean section. And it is only done in public health facilities. And if we don't reprioritize and go to those facilities for to get this data, it will become a problem because all the basic healthcare provision fund facilities, up to 323 of them, they are doing that. All the public health facilities, all the government facilities are also doing ANC. So if you are now looking at probably private hospitals or even faith-based hospitals where where you have your comprehensive health centers, you will not get them. So there is need to reprioritize in my state for you to be able to get these people. Because since its inception, more than almost 200,000 people have benefited from this, even those from other states. So the way forward is to, those facilities, they have those comprehensive health centers, they should try and reprioritize to be able to catch these people. Thank you.
All right. So the first problem is that we are not going to the right point that's the experience in their state. They are not going to the right point, and then there is need for us to do what? Reprioritize. So that's the key issue in that. So one, they have already provided free services, and then women are now going to hospital to deliver, but those other data collection information are not being done in that in those new public facilities. So you need to know whether we are going to prioritize to like visit more of those public integrated services that are there in those states. That's what you're saying, huh? All right. Yes. 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 So,
Okay.
Madam at the back, sorry, before you.
One of the reasons why we brought out the ANC coverage is we know the efforts over the past 2 years, and we have support for this. We're not even talking about the testing here, but we expect the women that we can reach if we're actually going to those ANCs to increase. But in some states, we still record 20%, 30%, whereas some states actually have as high as 96, 80%, against previous years that was on the average of about 30%. So we want to know what the challenge is. Is it that the data is not being reported? What are the issues here? Every data counts. Zero is data, right? But we need to know why we still have as low as 20% in some states. What are the issues and what are we going to do about it?
Good morning, everyone. Dr.
And I don't work with my husband, it's married one's work.
Good morning, everyone. Dr. Fomaideo, SAPC Rivers. For my state, I think my state is one of the states that still has poor antenatal coverage. And well, I say it's multifactorial, but let me just highlight a few points. First, like you rightly said, we have missing data because we know that these women go to private hospitals. We are not getting enough data from the private hospitals. That is on one side. Now, for the government side, unfortunately, we don't currently have the luxury that NAMBA has for free antenatal, but because we normally notice during the MNCH week, which we have twice a day, there's an increase in uptake of antenatal services when you have those free services, and also with delivery. And the Basic Healthcare Provision Fund is also helping that because, of course, if you register and you're able to have 4 antenatal, you're entitled to free delivery. But I think one of the key issues is the missing data. Beyond the poor uptake, even the services we've been able to render, are we able to document to the extent for which we are registered, both in the public and in private? Because even the MNCH week that there's an increase, the data is still not optimal. These are discussions we're still having at the state level.
These are facilities you also have TB services.
Definitely, yes.
Did they get their data?
I might not be able to speak on that.
So those are the things we can leverage on. I'm not sure if we understand what she had explained. And so the question we had asked is, these are also facilities where we provide TB services. And so how do we leverage this partnership to report those data? So the question is, if there's a private facility in your state that has reported TB data, why don't we have data on HIV from those facilities? I think those are the questions we start asking ourselves at the state level. These are conversations to stimulate and guide what is going to happen at the state. We've passed the era of sitting at the national. We're not going to populate the root cause for anybody. But we're saying we need to go back to the state and find out what it is. Because if we sit here and discuss, we cannot tell you what is happening across the different states. That is where the marriage works. Because from now on now, he's going to be reviewing my data for me while I sleep. Abi, won't you do it?
Okay.
So he's going to be reviewing the data for me. So please, my brothers and sisters, HIV at the state level, transfer your responsibility of reviewing data to the TB, right? Please, let's clap for ourselves. Let's clap for the TB state managers. They've agreed to do that for us, haven't they? this marriage has not worked. But it has to work. And I think that's the point. That we have opportunities that we can leverage on. We just have to be deliberate. If your colleague at the state is overseeing a facility and is going to that facility, how about having a peep at your work there to say, okay, where I visited yesterday, this is actually what happened. And when you're going to another, you can actually have shared responsibility. Or you're going to tell say, whilst you go there, please help me look at my HIV data. I'm going to other places, I'll look at your TB data, and it makes it easier for all of us. Thank you.
So thank you. Good morning, all. My name is Dr. Goni Imam Ali, Program Manager for TB and Leprosy Control in Borno State. Borno State is one of the states that has gaps in ANC coverage that attributed to increase in maternal and neonatal mortality in the state. So we are the third worst state in terms of maternal and neonatal mortality after Kano and Katsina. Then say that we are going to look what are the root causes of this problem. So we identify that access is a problem due to insecurity. Apart of that, then you will have gap in human resource for health. Then attitude of our staff also contributed to that. And the insecurity lead to what? High poverty index. The first thing Honorable Commissioner did, he looked at the innovation of Tanzania, Safer Birth Bundle of Care. He is the one that come with the initiative to Nigeria, and the Honorable Minister of Health welcomed that innovation. Started in Borno, I think other two states, is it Gombe and Jigawa, they state adopting that Safer Birth Bundle of Care, implemented in 6 facilities. So the outcome of that, after 6 months, facilities that are reporting 12 cases, now the case has been dropped to 2 in 6 months, and there is increase in ANC in the state. Secondly, issue of human resource for health. The state governor has built 2 additional school of nursing, and the nursing council approved community nursing. That is short course program for community midwife in 2 years. This year, by the end of this year, we are expecting over 1,000 community nurses and midwife will be graduated. So that one would pull the gap of human resource for health. And over 1,000 primary health care has been revitalized. We also come with this emergency envelope services now onboarded in Borno State this year. An issue of our attitude, human staff attitude toward patient care. We identify this is one of the factors that preventing the patient coming to facilities. Also, the staff has been trained on clinical governance. So clinical governance is a course that will protect the right of the patient and of the hospital staff. So with that, we have seen a lot of improvement. And this pre-antenatal and pre-cesarean section is there in Borno State for over 4 years, even before the federal government has pronounced. So we have delayed in implementing public basic health insurance scheme also has been implemented that year. So with these innovations and implementations of these activities, so I hope Borno State will improve, will change the outcome, and patients will be motivated to attend ANC.
3 key issues is well noted. The last person here before we go to the online. Sorry, just 1 minute, I will come back to you.
Okay, thank you so much. My name is Dr. Enobong Akpan, the program manager for the State Agency for the Control of AIDS in Akwa Ibom. While I want to add my voice to the issues around ANC, I just want to say a word or two on the integration issue that was deposited earlier. As long as you have partners that are being funded by their own different organizations, you would always not get it right in terms of HIV/TB integration until there is a deliberate government policy that speaks to this integration from the SDP to the community and to the facility up to the state levels. I think that if we can have all of that together, I think we'll get it right. Now back to the issue. And the ANC has actually been a challenge in Akwa Ibom. And I must say here that one of the major issues that had contributed to that the past years has been the issue of human resources for health. You've had a lot of areas, especially in the remote communities, where you don't even have primary health care centers that are working. Some of the primary health care centers are understaffed, some don't even have equipment at all. And you would imagine what will happen to a pregnant woman that goes into labor and they wouldn't find a PHC close by. So, and you know, these things spread like wildfire, and they begin to lose confidence in the system and think that the TBS that is close to them that they can always rush to. And then everybody now establishes that mindset that, oh, we don't have a working PHC, let us all go to the TBS. But the good news is that recently the governor has shown his intention to address that by recruiting about 3,000 healthcare workers in Akwa Ibom. That recruitment process started sometime this week, and I think will be completed by the end of the week. And we are hoping that that will solve that problem. But the other issues has been data, missing data, and my sister also mentioned it, and we had that problem. Some private hospitals, we noticed that they were not giving data, and we are addressing that. And we've also seen that some faith-based organizations were also, giving these services and were not captured. So the recent FBO mapping that was initiated by NACA across the states has really helped, because it has helped us to identify some of these FBOs that were rendering HIV services, including ANC services, and we are bringing them on board. Let me not speak too much about other issues within the community, the religious and cultural issues that are very big issues within our communities. And then I think we can begin to address that in a systemic pattern and to ensure that we can get it. Our state health insurance was not there before, but it has come on board very strong. And we have as a policy in the state that the pregnant women are declared vulnerable, and so they are enrolled into the state health insurance scheme free of charge. Although some people still drag their feet in enrollment because of these persistent myths and misconceptions that has been around the place. But let me also say that the SASCAP units in the Ministry of Health in Akwa Ibom did a great job. Before now, we had a lot of TBS that was on ENDAS that were not supposed to be there because they had closed out. But ENDAS still retained those TBS, and it made it seem as if our reporting rate was low. But we had to go around it. I had to work closely with our SASCAP brothers, and we had to update our TBA mapping and to make it more realistic, and our reporting rate has really improved.
All right, thank you so much.
So
Please,
that's
a round of applause.
that's what we're doing, and we'll continue to do more.
A round of applause, please. Can we go to the online people? Online people, is there anybody raising hand from the online? Any hand up? Is it a musician? Okay, please, you can talk.
All right, thank you very much. My name is Anyedi. Yeah, my name is Anyedi Akpan, and I represent Drug Harm Reduction Advocacy Network. So good to see my SACA head at the meeting. So what I would just like to contribute to this discussion around integration is something that I need to...
not integration, boss. We have
understand
integration.
Yeah, okay. So
we're talking about suboptimal use of ANC.
Okay, so maybe I'll wait for when integration is the discussion on integration is on.
God bless you, my brother. All right. Any other person?
Okay, Dr. Emperor,
Okay.
thank you. Good morning, everyone.
Questions? All right.
Can you hear me?
Yeah, these comments, the first comment said we can leverage on the data harmonization. I think everybody is just believing that this data harmonization needs to occur. Cultural belief are also responsible for most of the low ANC coverage. We need to prioritize demand creation for ANC. And also we'd like to talk about, okay, we leave integration till we start with time for exam. We can use the outreaches for health education to enhance ASC visits, okay? Please, a round of applause for those online. We're closing down on this and we're moving down to TB. Just let me give the boss.
Good morning, everyone. The data is there. And with the data, a lot of policy documents have come up. We know that the health-seeking behavior for pregnant women in the South is different from what we have in the North. Removing the attitude of healthcare workers and the out of stock and the performance of the BHCs as one of the major factors that make women don't to have their babies in the primary healthcare centers. I think that it will not be nice, it will not be practicable to have one particular direction, because the gentleman here has mentioned cultural aspect of it. So we should try to develop something that will work. If you want to force every woman to come to the ANC, it's not going to work, especially in the North. And in the North, you also remember the aspect of a man going to deliver a woman at home. So in our fashioning days, we should be able to put in something that is practicable. We've been talking about bringing every woman to the hospital. We know it's the best practice because there are other things you check, you look out for, even after delivery. But making sure that we achieve that PMTCT, starting with ANC, we must put on and adjust our cap to run with something that is practicable. Thank you. I don't know if I'm pushing it away, but I don't know whether you've passed this, but I think I should just place this on the table.
Yeah, I think, sorry, let's go to the other sections, please, because we are already 1 hour behind schedule. That's why we say you should come early. And when we mention something, please raise your hand quick, so that we can capture you as well. So when we are doing summary, I'll come to you. So we have 1 minute summary. So please, you see, the essence of this is to support the state to actually start working together as a team. Because it's not just looking at the results, or we have seen that people think that if we come together, we can achieve more than what we are just achieving recently. I'm telling you, when it comes to private sector, TB is doing very well in private sector. And therefore, if HIV is not doing well in private sector, is an opportunity for that to be enhanced. Because you can just go back today, pick the whole list of private sector where TB is implementing, and do your own extension of services to the. And let me tell you something, HIV testing that we are talking about is no longer something that has to do with capacity. Many people can test for HIV even in their house now. Are you getting what I'm saying? But the question now is, how much are we capturing the data that those people have? Is our tools even there for them to even record what they are doing? Are we reaching out to them? So we can do that vice versa. If there are facilities where HIV, even for our dot expansion, we intentionally ask HIV, is there any ART center that you don't have a dot service. So even if that state is saturated with the number we must do in that facility. So we should look at that also on our own side. So one of the outcome of this thing is that in the next meeting we are going to have, we are going to request that the HIV partners, our colleagues, not partners, HIV colleagues in the state should be able to provide us private sector information they have based on where TB is also providing services. So as we are writing that letter, we'll give you as part of the information you come with us, because we are also going, by next time, we are not going to be presenting alone. We are going to make sure you are going to be the people to present a lot of the information and give us the analysis we need from you as a state program. Is that okay? Please, a round of applause for me. So quickly, let's go. Scroll down, scroll down. I didn't say you should. Just follow me, eh? So for the next one, where the wife has run away with Dr. Money, please come back. So please, we are looking at gap in medicines and commodity, and available commodity won't cover. This one is beyond you here. This is a big English, but it's beyond you here. But one good thing we need to do is, are we managing the drugs and the commodities that is even available for you in the right format? Are there wastages? If I give you 100 commodities to test, are they expiring? So I'll just request for 2 people to make a comment, and then we'll go to the next one. This one, don't go and comment on me on there is a gap. I know there is a gap. The gap is no longer information to me. What I want to know is the one that you are being supplied. Do you think it is well managed? Eh? No. Don't be doing science and things.
All right, thank you very much, Emperor. All right, so what have we done? And that's what are we doing to ensure that what we get from from our partners, and of course from the National TB Control Program, in terms of commodities, of course, for TB, and how is our management been? Well, let me just quickly say that we know that we can't have a 100% strengthened logistics unit. But of course, in the state, we try as much as possible to align ourselves as much as possible with the well-coordinated LMCU or logistics management unit from the national. And of course, we have a very robust LMCU unit. Let me just say, currently, our LMC in Ondo State is in the hands of very competent individuals. And of course, the National TB Control Program has also assisted the LMCU unit with the fact that every opportunity that we have new individuals joining us for one reason or the other, a previous retirement and all of that, and then new persons are coming on. There's a lot of support in terms of trainings and all of that, which has happened even with our most recent logistician and also the LMCU unit. So for us, we don't even have any issues with commodity. In fact, the more you bring it to us, we will be accepted.
Okay, do we have just one program manager who thinks that there is a gap in terms of management of the products, commodities at the state level? A gap. Hey, the giant man. I'll give that boss.
Thank you very much. Thank you, Dr. Emperor, for giving me the opportunity. Yes, presently there is a gap that we observe, especially in the use of the testing kit commodity. There are situations whereby, the way the LMCU in various states distribute, and they distribute through facility levels and like that. So at times, some of us partners that we implement community HTS in those states, we also have access to them in some other states. So we have situations where we have commodity in some facilities unused. And at the community level, the kits we have are exhausted. In fact, in some states in the Southwest, we have a situation whereby some of those in the facility expired or about to expire, if not for the proactiveness of some of our own officers on the field that has to go into the facility out of what they. So I think there's need for proper coordination, improved. Yeah, there is coordination, but the coordination need to be improved between the implementing partners for the TB HIV integration in at the state level, as well as the HIV, those managing the HIV commodity. We need to speak more. This gap is very wide. The NASCAP, the SACA, we are trying our best, but there are a lot of intrigues and some other things that go on at the state level. So
okay, so the one key thing is still boiling down to what we have been discussing initially. When we say data, I hope we know that data is not just the patients alone, calculating the patient. Data rolls down to commodities, to drugs, to everything. So don't please, when they say harmonization, don't depend on saying I saw 20,000 patients, you saw 5,000. Don't depend on that, because as you're doing that, you see why your data harmonization, even to the drugs and commodities, are very important is that when you are going to quantify your needs, you'll be able to get the accurate number of your needs. Is that okay? So please, so you don't encourage harmonization, that kind of harmonization where we count only number of patients. Let's count it to the point of the commodities, because those commodities, that means even your budgeting, your plan, even if you're putting it in your state budget, how will you know the number to put in your state budget if you don't have accurate logistic and commodity data? So please, very important. We move straight to number 2, drug resistance TB. About 53% of them target reach. A drug resistance survey is ongoing to rebase the targets. Yes, even though we are rebasing the target, but the question is that, can somebody tell us why we are getting low target? If you look at every other target, we are surpassing it. Is it not? Testing for HIV, even some states are hitting 100% now for testing for HIV, except during the period they have like a low test kits availability. But if there are enough test kits, most states go as far as going. In fact, the worst state in my zone this year in this quarter was just 80-something%. So you can see it's very, very high. But the problem now we're having now is that for drug-resistant TB, every time you see the other line, it's always yellow. It's always what? Yellow. So why is it always yellow? Shehu, there is a way. Why are we not reaching the target for drug-resistant TB as against what we used to have? Yes.
Yeah, thank you very much. For my state, I have already reached my target, but I think I have reached my target. It's 40. I reported 42 per quarter. But I think we had a round table when we are having issues of our gap, that is the target and enrollment gap. What we did in KB was we are getting cases from DST, but we are not getting DRT. What's the problem? Why our cases are going up? We come to realize that we are not targeting those that are presumptive for DRTB. Who are those presumptive for DRTB? We are looking at relapse. We are looking at those that failed treatment. We are looking at even HIV co-infected patient. But our general health workers, we are only looking at presumptive. They don't care to ask whether you are resistant, you have taken treatment before or not. So if you targeted only people that comes, you don't ask whether they have taken treatment before or not, you may lose most of our patients. And also, we have been getting DRTB in the States, but our general healthcare workers also have issues with reporting. I went for supervision sometimes. I was checking my records. I saw a general healthcare worker placing DRTB on DSTB treatment because of there is no alert. Before now, we have what we call alerts from gene expert coming to us. It will alert the program manager, the TBLS, that is a DRTB in a specific gene expert. But now there is no alert. So you see a general healthcare worker, what his only concern is MTB detected. He will not look at whether it's resistant or not. So we have been missing a lot of patients, a lot of DRTB in that context. So what we are doing now is to make sure that all results before placing on treatment, supervisors go around to check so that we remove such things. Why gap, in closing gap for treatment, also we look at most of these patients are coming from rural communities. And you know, most of our facilities are at the state level. If you want to do the baseline, if you want to do so many things in the state. But when we decentralize back to general hospital, signing MOU with general hospital. Some of the baselines can be done at local government level, while some sample can be transported to the state. So in that, within 24 hours. And also with this, our BPAL, that have reduced number of tests. Just if you know one or two things, you can place patient on treatment is helping us.
Please, a round of applause. I think he has touched very key thing. One is that tracking of the patient to identify retreatment is key. And then also making sure they have access to molecular testing. Okay. And then the next thing was also the issue of decentralization of services to cover the enrollment gap. And these steps have helped him to do what? To cover for the both for case notification. He had that his target is 40. Now he has hitting what? 42. It means that even your target they gave you was low. So it means that there are also more patients you are missing. No, but that is it, because you have 40 to reach, but you are now reaching 42. It means with more effort, you can actually reach 60. True or false? All right. So it's also boiled down to the same thing to almost all the states. You have anything?
So thank you very much. In Borno, we have two problems. One comes from national, the other one is with us in the state. First of all, Borno. Okay. So with us, I think it's also issue of access insecurity. We notify DRTB patients. For instance, in the quarter when we get 20, we are not able to enroll all, sometimes 15, 14. Some, they are in hard to reach LGS, particularly like Martin. You see insurgents account, all the patients, the people with the security will relocate to another local government, In the process of tracking this patient is very difficult. Some of the patients, they don't have even phone number. Just verbally, they will tell you they are in other LGA. If you went there, they will describe another location. And to track this patient, it need what? Money. Yeah, financial need. So this is one of the problem with the states in 100% enrollment of the RTV.
So, no, that's the national owner. I know what he wants to say. Yeah, don't worry. He has told me that before. So I know that one. I don't want him to. Don't worry. I know what he wants to say. So let's go to we are not doing this one, delay in TB land consumables. Yes. So, but let's go ahead. Scroll up. I think the only one. My Her Excellency Margaret on